Good morning. I call this Legislative Task Force on Aging to order on Thursday, July 25th, 2024. We are waiting for one more member to have quorum. We have Dr. Moon as the designee for the University of Minnesota this morning with us. And so thank you for your participation with us this morning since Dr. Gogler cannot be here. We are going to wait on approving the minutes, and we will move into welcome. Awesome. Now we do have quorum present for adoption of the minutes. Members, do you have any discussion to the minutes, any corrections to the minutes? Seeing none, all those in favor of adoption, please say aye. Aye. Any opposed? Hearing none, the minutes are adopted. We have with us a new member of the council of the task force. Welcome, Vice Chair, Senator Elise Mann. Are you feeling settled and we can do introductions?
Please.
Would you like to begin with yourself, or would you like for the task force members to begin? Okay, why don't we start with Ms. Schneider, and then we'll go around this way.
Good morning. Welcome, Senator Mann. Good to have you here. I'm Maureen Schneider. I'm the chair of the Minnesota Board on Aging.
Good morning, Senator, and we got to meet in the hallway. So welcome to the committee. I'm Representative Natalie Zalesnikar, and I represent District 3B. And I'm here having been a past nursing home administrator and nursing assistant, so nice to have you.
Would you like to say for how many years you've been doing that?
The nursing home?
Yeah.
40 years.
Okay. So a vast knowledge of that occupation. Mr. George.
Thank you, Madam Chair. I'm Andrew George. I'm the task force administrator.
And welcome, Dr. Mann. You and I came in together as legislators in the House. We know each other well, and I'm so excited to have your expertise at the table. Thank you.
And I'm Jen Foley. I represent the Minnesota Council on Disabilities, and I'm from St. Cloud, Minnesota.
Hi, Senator Mann. My name is Rajan Moon, and I'm actually representing Dr. Joe Gogler from the Center for Healthy Aging and Innovation at the University of Minnesota.
Good morning, everyone. Thank you for having me. I'm Senator Elise Mann, and I represent Senate District 50, which is half of Bloomington and half of Edina. I am interested in this topic and very excited to be here because as a physician, a lot of my patient population is aging. And I see, as an ER physician specifically, how the cracks in our system have left our aging population vulnerable to poor outcomes. And so I'm very excited to be here to help change that.
And we do have two members online. If we could, Senator Housley, if you would introduce yourself.
Thank you, Madam Chair. Hello, Senator Mann, Senator Corrie Housley. I represent the Stillwater area. Good to have you on the committee.
And Councilwoman Armstrong.
Good morning, everyone. My name is Agatha Armstrong. I'm the vice chair of the Grand Portage Tribal Council, and I was invited to be a part of this group through the Minnesota Indian Affairs Council.
Awesome, and that is our task force, and I'm excited to have everyone with us here today. Item number 4 on our agenda is public testimony. No one signed up in advance, so if there is anyone from the public here today who would like to have 3 minutes for public testimony. Seeing none, we'll move forward with the rest of the agenda. Item number 5 is Own Your Future presentation, and we have Mary Olson Baker, Nikki Peterson, and Fred Anderson. If you would come to the dais, please. When you're ready, if you'll state your name for the record and then begin your testimony, please. And when you state your name for the record, if you'll also state your position titles, I think that's helpful for the public to know. Thank you.
Thank you, Madam Chair. I think I'll start while we get the PowerPoint up, if that's all right. Thank you, Madam Chair and task force members for having us here today. My name is Mary Olson Baker, and I am the Quality Assurance and Improvement Manager for Aging and Adult Services at the Department of Human Services. We want to thank you for this opportunity to come and share information about the Own Your Future initiative. We feel strongly that our most recent work can not only provide data to inform your decisions, but also provide recommendations that can be implemented to provide affordable options for Minnesota's accessing long-term services and supports, or LTSS, especially those that are middle income, which I know from previous task force meetings is an area of particular interest to all of you. Now I want to introduce staff or representatives of our Own Your Future Initiative Advisory Group. First, we have Nikki Peterson, who is the Quality Assurance and Improvement Planner at DHS. Nikki has been leading the efforts for the Own Your Future Initiative for well over a year, or since Lorraine Knatterud retired in December of 2023. We also have Fred Anderson from the Department of Commerce. Fred and Commerce have been a key partner for Own Your Future. Fred since 2014 and Commerce for a much longer time for that. So I've turned this over to Nikki.
Thank you, Mary. Good morning, Madam Chair and task force members. My name is Nikki Peterson. I'm the Quality Assurance and Improvement Manager. I said Mary's. I'm the, gave myself a promotion. I'm only the planner in Aging and Adult Services. I just want to state I have way more information than we will have time to cover today. So I just want to mention I won't cover all of the content on each slide, but I'll highlight the most important points. And I hope you can review the remaining information as you're able. Before jumping in though, I'll turn it over to Fred to just introduce himself.
Hello, I'm Fred Anderson. I'm the Chief Life Actuary at the Minnesota Department of Commerce. And my background is helping to ensure the financial solvency or claims paying ability of life insurers. But I've also been active in long-term care innovation issues at the state and in coordination with other states.
So first, I want to share information about Own Your Future. The purpose of the Own Your Future initiative is to educate Minnesotans on the importance of planning to identify their personal and financial options to meet their future LTSS needs, LTSS being long-term services and supports. This is significant because we know 70% of those over age 65 will need long-term care at some point in their lives. And unfortunately, there is a lot of misinformation that leads people to believe that Medicare will cover this cost, which is simply not the case. So Own Your Future has a public-private stakeholder group. Group members come together to develop policy reform initiatives for financing long-term care needs. The group started formally back in 2012 with a variety of stakeholders from both the public and private sector. Other agency partners, employers, industry representatives, provider and community organizations. It's really important for this work that we do have the input of the public and private sector because to find solutions, we need everyone to be at the table. The group has grown and is more informal right now. We just had a meeting and there were over 30 representatives there. Many of the same people that started the original Own Your Future group back in 2012, but we've also added more community partners, have partners from DEED, Age Friendly Minnesota, and the Minnesota Board on Aging. So Own Your Future has always been an effort led by DHS Aging and Adult Services, but in partnership with the Minnesota Board on Aging as well as the Department of Commerce. So before going any further, I'd just like to clarify the different roles of each agency. So Aging and Adult Services is invested in this work because part of our role is to provide unbiased resources, which includes financing options for LTSS. We're responsible also for monitoring and developing a full spectrum of services along the care continuum. So at this point, I'd like to draw your attention to the graphic on the slides. This is our spectrum of services here in Minnesota. And I like to think of those on the left side of this continuum as those with low care needs. These are people who might need more light touch services as their care needs are not too significant. And the thought is that as you move along the continuum to the right, there are those who have more and more significant care needs along and need a higher level of care. These folks receive means-tested services, and generally speaking, as you move along the continuum, services tend to become more expensive. I share this graphic just to remind you of the full spectrum of work, because for Own Your Future, we have to step back and look at the system as a whole. Where do the majority of older Minnesotans currently sit on the spectrum right now? Where are they going to be 5 years from now? Where are they going to be 10 years from now? What happens if we make investments further upstream or to the left of the graphic when interventions might be cheaper? Can we delay the onset of more significant care needs? And now I'll let Fred talk about the role of the Department of Commerce in Own Your Future.
Okay, you'll hear a lot about the public-private partnership, and a big piece of the private part is the activity of private insurance companies. So the Minnesota Department of Commerce, we regulate the private insurance industry. So we evaluate the claims paying ability, rates, and innovative proposals associated with long-term care insurance. We approve insurance products offered for sale to Minnesotans and also advise on legislation in areas of insurance innovation. And of course, especially through this effort, we coordinate with other agencies, including DHS.
So I'll just briefly talk about the history of Own Your Future because it does lead up to our most recent studies. The history can really be broken down into 3 phases. The work initially began with phase 1 back in 2010 after recognizing the need for long-term care education and planning. Noticing that there weren't many product options that were affordable for the middle income, the second phase of work started in 2012 and really focused on identifying and developing product options that would be more financially feasible for the middle class. In just a minute, Fred will be talking about one of those product options. After Fred presents on that, we'll cover the most recent phase that began in 2021, the long-term care system transformation in our most recent studies. But Fred, I'll turn it back to you to talk about life stage.
Okay, one of Own Your Future's major products was developing insurance product concepts for the middle income market. Ideally, everybody would be able to afford an insurance product that covered all costs, including catastrophic costs. But of course, those products have proven to be very expensive. So ways to lower costs of long-term care insurance are to limit coverage below catastrophic amounts and also to encourage people at earlier ages to purchase those products. And one concept that gets at both affordability issues is life stage. So this takes a term life insurance product that's popular with young families and converts it to long-term care once the term life need is lower. The state adopted legislation to clarify the approvability of such a product in 2022, and there's been interest expressed by several insurance companies to offer this product. It would also be helpful for other states to clarify the approvability of this type of product. So it would encourage companies to sell such a product at a broader scale to help justify the expenses of developing this type of product.
So now we'll get to Own Your Future Phase 3.0, which focused on a full system transformation, since it was clear that our current system wasn't really designed to meet the needs of older Minnesotans who are living longer than we ever expected. So with that, legislation was passed that allowed for 2 studies. A demographic study that provides a baseline of demographics for Minnesotans age 65 and older, It also summarizes the current use of Medicaid for LTSS for older Minnesotans and uses that to then project future Medicaid usage and costs going out to the year 2035. The second study is known as the transformative study. Its primary objectives were to improve access, integrate funding options, and transform the system. The transformative study contains an analysis of services and product options for the middle income, which is referred to as the quote-unquote red box. The study relied on stakeholder and expert consultants' input to develop three solutions or recommendations for integrating LTSS funding options that would have the ability to transform the system. And this slide, I just wanted it as easy as possible for everyone here or watching it online to access the reports. So it has the reports and their authors. I do want to just point out that there are two reports that then make up the demographic study. The first one informed the second one. So the demographic, social, and economic characteristics then informed the LTSS for Minnesota's older population, the utilization of Medicaid payments.
May I just ask one question?
Of course.
Okay, so when you say that stakeholders informed, can you just, for the people who are listening at home, kind of give a very high level of who were those stakeholders at the table?
Yep, and I do have that on a further slide. Do you want me?
Oh, perfect, that's
Okay,
perfect. All right, great.
Thank you, Madam Chair. I included this slide just because I encourage everyone who's interested in this topic to read at least the executive summary of these reports. It provides so much more information that could really inform your work and your ultimate report. So now getting to the key findings of these studies. I know the State Demographer's Office has presented to the task force twice already, so I don't want to spend too much time here. We know that our older adult population is increasing at a very rapid pace. And due to that, especially growth among those who are 75 to 84 and 85 and older, the use of Medicaid LTSS could increase by over 25% by 2035, which would significantly increase the costs of Medicaid for LTSS here in Minnesota. In addition, the mix of LTSS services could change. We see since COVID, there is a trend away from nursing home use and towards community-based care. So we're currently in the midst of a new study that would use even more recent data going through June of 2023 to project LTSS utilization and costs through 2035 again. This study will also involve simulations that could test different scenarios for future demographic change, or if we want to see what would happen if the cost of these services was changed, what would that lead 10 years out. So results from that study should be available in the fall. The data from the demographic study and further analysis of the population then was used to inform the transformative study and those that participated in it. As I said, when we jumped to the transformative study, there really was a focus on the middle income. This slide provides a pretty generalized relationship between family income level and the available options for services and financing. For example, under the Medicaid program, you see that people who make up to $25,000 are eligible for that. You do see kind of a grayed out box for those in the $25,000 to $50,000, since we know that depending on circumstances and spend down, they could be eligible for that program. But for example, those middle income in the red box, you don't see too many solid blue lines besides out of pocket or at the very top, private insurance. Do want to point out that programs and services funded through the Older Americans Act are available to all people over the age of 65, regardless of their income, but these services are not guaranteed, and currently the funding is static. it's not going to be able to keep up with the increasing need nor the increasing cost of care that we're seeing. And as you can see here, like I pointed out, we have 2/3 of our older Minnesotans in the middle income without many affordable options for them. And so if anyone's a little bit overwhelmed with what these studies I've shared so far, we do have good news. The transformative study asked partners to come together to design solutions. And I like to think of it as an equivalent of when you get stuck in the snow in the winter. One time in college, I got pretty much the entire front half of my car stuck in a snowbank. Didn't think I was ever going to get out, couldn't find any solutions, but one by one, people in their houses grabbed a shovel, came out to help. Motorists stopped, someone had changed. We were able to work together and get my car out of the snowbank, and that's kind of what we did with our different stakeholders. I cannot get this to the next slide. There we go. So we had two main groups for the transformative study. The first group had 25 stakeholders from Minnesota who met over 5 sessions. Some of the sessions were held on multiple dates just to ensure that as many stakeholders could make the sessions were able. The stakeholders had to have a connection to Minnesota, either working or living here. And many of them represented the same areas of the Own Your Future group. The insurance sector, service providers, community organizations, and some were traditional Own Your Future group members. This group was asked to focus on the community. They were asked to kind of wear 2 hats in their professional field and the expertise that they brought, but also as Minnesotans and thinking about what type of care they would want to receive, what they want for their family, friends, and loved ones. They were also encouraged to leverage the data that we had available and think about outcomes to create alternative LTSS funding options. And in the end, they were the ultimate decision makers. We had another group of 44 advisory consultant and expert panelists. This group had local and national representatives, again, people from the private and public sectors, and was really comprised of industry leaders, insurance brokers and agents, those dealing with employee benefits, personal financial advisors, people from other states' governments who are also dealing with the same issues, those who are knowledgeable about paid and unpaid caregivers, some technology solutions, as well as those familiar with the workforce shortage. And their job was really to inform the main group of Minnesota stakeholders of the current landscape of aging in Minnesota and just make sure everyone had an equal grounding. They also shared information about the population and projected growth from the demographic study. As the process to design these solutions or recommendations was very iterative, they were also tasked with providing feedback and guidance as the Minnesota stakeholders design their solutions. Information regarding the stakeholders, expert consultants, and the details of each of their different sessions that they held can be found in an appendix to the transformative study if anyone else does have further questions about who was involved. During one of the initial meetings, our group of Minnesota stakeholders were asked what they wanted to see in their final solutions or recommendations, what was important to them. And they shared they really wanted to see something that incorporated care navigation and coordination. Also realizing that Minnesota is and has been a leader in LTSS for many years, they wanted to build off and strengthen already successful programs in existence, such as the Minnesota Senior Health Options, or MSHO, and the Senior Linkage Line. Stakeholders also realized, again, this issue isn't something that neither the public nor the private sector can resolve alone. They want to see something where we're coming together and collaborating. Further, they wanted to see something that would support caregivers both financially as well as their overall well-being, so physical and emotional well-being as well. Accessible technology and ensuring that any solutions that came would provide assistance to all Minnesotans, regardless of where they lived or what their cultural beliefs may be, was also of great importance to this group. Now I get to share what they ultimately designed. The first is a centralized care navigation and support structure for all older adults with a care need. This would be leveraging existing services and providing strong awareness and education to support Minnesotans and their care needs, as well as those of their caregivers. Expanding upon the senior linkage line was something that was mentioned quite frequently when discussing this recommendation, ensuring that they had the adequate funding to keep up with the increasing need for their services, ensuring that they can use technology to serve people and access resources in their preferred methods. So, if it's calling or if it's using an enhanced online tool that allows people to access the resources through self-service options. And most importantly, ensuring that every single Minnesotan is aware that they exist and the resources that they can provide. The second solution that was designed was the Medicare Companion product. So this would be a new product that integrates care. People don't like to split themselves in half or think when they go to the doctor, is their concern something that is acute and will be covered by Medicare, or is it related to LTSS and would need to be covered another way? This is something that would coordinate their acute needs through Medicare, as well as another product for their LTSS care needs. And the last idea was a catastrophic light state-based program. So an obligatory state program that would provide funds to pay for long-term services and supports for 5 years, but after a 2-year elimination period. This would reduce the strain of more costly, long-lasting care needs. So if a person does need a high level of skilled care for 10 years, that is quite the financial strain. This also would allow then the private market to come in with solutions for up to, they could have design products that people could purchase to cover those initial 2 years. Yes?
I'm listening to this. Thank you. Thank you, Vice Chairman. As I'm listening to this, okay, so you've got the 2-year, and we just want to make sure that everybody understands the 2-year and then the 5-year. So the 2-year would be paid for by your private insurance, is that what I'm hearing?
Yes, the idea would be that, product options could be developed for that.
Okay, and then, correct me if I'm wrong, because I might be.
Yep.
Most people who enter long-term care, it's 2.5 years, is that correct?
Mm-hmm.
Okay, and then would that 5-year period then, after the 2-year elimination, be equivalent to reinsurance that we currently have in the medical market or not?
I don't believe so.
I'm just trying to figure this out in my head.
Yeah, I mean, my understanding is there would be state funding for those years 2 through 5, and that's why it's called a catastrophic light program, because we were anticipating that covering all benefits over however long, care was needed would probably be too expensive. So we were trying to come up with something
Okay.
a little more attainable.
So it's not really reinsurance. The private company's not going to be carrying it and then we pay them back. It's not like that.
Correct.
So it would be that for those individuals who are outside of the norm of 2.5 years, then they become the state, and I don't want to say it like that. The obligation for their care would fall to the state, and so the private companies could plan actuarially as to what their costs would be as they're doing their premiums. So it would keep the premiums lower because they're not looking for the outliers. Is that correct? Is that what I'm hearing?
That's exactly right.
Okay, perfect. Thank you. Please continue.
Yes, of course. That actually brings up a great point because, so the transformative report has a whole section devoted to actuarial considerations and uses actuarial modeling to then estimate the different costs of these different programs. Same with different options. So, this would be what it would be like if we designed like the full Cadillac package. This is what the benefits would be. This is how many people we are estimating that would benefit from this program. This would be the total cost, and these are different ways that you could finance it. I highly encourage looking at that. The modeling was just intended to be indicative, to just give realistic, high-level expectations on the cost and impacts of these additional programs. So at the end of the process with our stakeholders, they were asked to rank the 3 different recommendations. They ranked each option as to the degree it would improve upon our current system, and it was based on a predetermined list of essential criteria that they developed. Examples of this would be access or equity of access, cost, how understandable the program would be, how marketable the program could be. And as you can see here on the slide, and it's another one of the main points I hope everyone takes from this presentation, recommendation number 1 was the highest for improvement over the current system that we have now. Stakeholders appreciated that it would offer support that allow family, friends, and neighbors to deliver care, so care preferences could be considered. They also liked that there wasn't a waiting period for this recommendation. Wasn't like the 3rd recommendation where you would have to find a way to provide care for those first 2 years. They also liked that it provided equal access. Any older Minnesotan with a care need or their caretaker could benefit from this and could access it. There was no eligibility requirement, and they appreciated that. This slide also has the page number 127 of the transformative study that has the full rankings of each recommendations. But before moving along, I do want to point out that these recommendations or the solutions from our stakeholders are not mutually exclusive. We don't have to pick just one. There could be, we're implementing one while doing further investigation and research of how we might want to design one of the other recommendations in the future. The last key point from today's presentation is, along with the findings from the 3.0 studies, the Own Your Future group recommends continuing to increase affordable product options for the middle income. And this can be done by promoting Life Stage, which Fred described earlier, and continuing our work on that, but also allowing the sale of limited duration care policies in Minnesota. And since this falls into the insurance arena, I'll let Fred share a little bit more about what this is.
Hi, this is another example of a product that would be more affordable for the middle income market. It's been well thought out at the national level, at the National Association of Insurance Commissioners. There is a model law involved. I think states' main concern before this national work was done was people understanding what they're buying. So these products would generally provide 1 year of care less, so it wouldn't be officially called long-term care. But we find that everyone's situation is different, and this would be a logical option for some people in the market. It wouldn't be for everybody, but it would be for people in certain situations. So our hope is to, take the steps through our agency in coordination with DHS to perhaps introduce this type of product design at the legislature for consideration, and it would probably follow the NAIC model.
And as someone who has a pre-existing condition that makes them ineligible for traditional long-term care insurance, I could say from my personal point of view, having some care, even though it wouldn't, last longer than a year, some coverage is better than nothing.
Would you say a little bit more about that? Because I don't think people know that. Please go ahead.
So if you have certain pre-existing conditions, you will not be eligible for traditional long-term care insurance. It's simply too expensive for the insurance companies to cover. Also, age sometimes is, if one is older, they might be ineligible for the traditional policies. And so we have heard from a lot of people in those situations. I know it's only 1 year of coverage, but that's better than nothing, and I would like to invest something to help with that first year.
So as we're trying to raise awareness, using this committee to raise awareness, I think the question I'm asking you is, could you state what some of those pre-existing conditions might be?
Sure. It could be a stroke, heart defect or heart disease, traumatic brain injury. Can you think of any more at the top of your head? Previous cancer diagnosis.
Well, and it'd be like, isn't like hereditary genetics, if you have something that's diagnosed, then you hear all the time about people don't want to find out if they have this hereditary genes, and that's, would be part of it as well. So, Fred, can you think of anything else? Okay. Just some examples. We
Okay,
could probably
thank
give
you.
you more exact examples if you'd like.
I think people need to understand, to your point, Mr. Anderson, people need to understand what these products would or would not cover, right? And all of the things that you just listed are most of the reasons that we need healthcare, right? So, okay, I'm sorry for interrupting, please continue.
Oh, and actually that brings us to the end of the presentation. Just want to really thank you for this opportunity to share not only with you, but also everyone else in the room and who is listening online.
So Representative Cooper, if I could just add to that last point.
Yes.
The part that Nikki talked about in the very beginning is that where Own Your Future started and all of the work that was part of Project 2030 and Transform 2010 and Aging 2030 is the work that Lorraine Canadarud did, was always about educating people about needing to prepare for your future long-term care needs or LTSS needs. And so it is that planning, and like as Nikki said, age can be a factor. And so it's really hard people don't want to invest in long-term care insurance because of the cost. And there's also that misperception that Nikki also pointed out that people think, oh, well, as I get older, Medicare will either cover it or I'll be eligible for Medicaid. And so there is an assumption about, that it will be covered and I'll be cared for. It's similar to that people feel that Social Security will provide the financial support they need. And we all are aware that that's just one leg of the stool in terms of planning. So it's issues that have been around for a very long time and been talked about in this field, for as long as I've been in the field, which is over 30 years.
Thank you very much for that. Members of the task force, do you have any questions? Ms. Schneider.
Thank you, Madam Chair, and thank you, folks, for your presentation. I have three items that I would like just a little bit more on, please. The first one probably would be for you, Fred, on the Life Stage New Insurance product. Do you have any idea how long, assuming everything was approved and all of that, how long it would take to bring some of these products to the marketplace?
Mr. Anderson.
Yeah, my guess is it would take a year if a company decided, okay, we're going to green light this thing, to just do all the background work and educate their sales staff and make filings with states and so on and so forth. We're still at a stage where we're trying to reach out to other states to encourage them to also make it clear that this type of product would be approvable. One other area that I've heard about is the potential for a large group to be kind of a pilot case for this type of product. So maybe like Minnesota State employees or something like that.
I see.
Could be a pilot case. I will mention that I would buy this product. Like, I think it's a really good product, and so I need to do some work, and I need to get other states involved, but I think it'll eventually happen. It just takes a little bit of time.
Thank you very much. May I proceed, Madam Chair?
Please, Ms. Schneider.
I have a second question. You talked about your 25 Minnesota stakeholders. Do you know, Nikki, probably, do you know what the makeup was, rural versus metro? Do you happen to recall that?
I do not off of, sorry. Please go ahead. Thank you. I do not off of the top of my head. I know we purposefully had someone representing one of our AAAs, our area agencies on aging, from the north and more of a rural region so that she could bring up issues that would need to be considered for rural populations.
Thank you. And then finally, on your recommendation number 1, you talked about providing the awareness piece. And I have been trying to raise awareness on aging for 35 years. I started out with saying the aging are coming, the aging are coming. And I still don't know what the key is to effective awareness raising. Have you had these conversations? Do you have any idea of how you would market going forward?
Ms. Schneider, that is a great question, and I would actually, I think, I would defer to the experts, the senior linkage line. I believe that they would probably have at least 3 ideas of how to expand their campaign if provided adequate funding to do so, so that people know that they exist, as well as, what people need to plan for and what people need to start thinking about. And that, yes, we had this increase in older Minnesotans that we need to be aware of.
I think you have a very relatable product idea. And I think the awareness needs to match that. Very relatable. Thank you very much.
Vice Chair Mann.
Thank you, Madam Chair. I have a few questions. One, I just want to lay a little skepticism on the table around recommendations 2 and 3, just because it seems like it's just more insurance. And we all know that there are issues with the private insurance market. I mean, as we have heard, long-term care insurance, you can't get it if you have all of the reasons why you would need long-term care insurance. And so we're asking younger families and younger people to start paying into, which sounds lovely, but if we all had the money to pay for all the insurances, health, disability, car, home, you name it, we wouldn't be having this conversation because everybody would be insured by the time they hit 65, right? But we don't have that. So I just wanted to throw that out there. And then equity piece too. I think private insurance, we know people get turned down, not just for because of their pre-existing conditions, their age, but for their race. And that's well documented, and so just also putting that on the table. But I have questions about recommendation 1. It sounds lovely, but what does it mean? Does it mean that there's like a central hub that someone calls the state and says, I need help, how can you help me? Do we need to build, I would imagine, to take care of all the people that would be calling in, like a 100-person new department to take care of that? And then to leverage pre-existing services, we know that the services we have are not enough to take care of all the people that need to be cared for. So are we building on top of this many new services? Like what, again, it sounds lovely on paper. What does that look like logistically?
Ms. Peterson or Ms. Olson? Or Baker, I'm sorry.
And yes, I can take this. I do want to point out, thank you for those questions, that our stakeholders also had skepticism about recommendation 2 and 3. People, especially an obligatory state program, they were very concerned about that. So I do want to just point out that if you look at the ratings from the stakeholders at the end of the process, kind of came to the same conclusion, and you can see other issues that they raised or concerns that perhaps with further study could be eliminated, but also. I'm not sure if you're aware of the senior linkage line. I have called them multiple times as a caregiver for a family member to learn about, my mom needs a ride to the doctor. Who does that in the area? However, they have limited funding, and they would need to increase staff to be able to handle more phone calls. I also think they have recognized, I know they are updating the platform for their online tool, mnhelp.info, but they would probably agree that it could use a large makeover. We could add in self-service tools, so when people go to it, you use some sort of AI to ask the person questions about why they're going there, to not only say, here are some service providers you can contact for that service, but also, have you thought about this? Which a lot of times as a caretaker, you don't know what you don't know. So you don't even know how to be asking it. I think about when I've called the senior linkage line for help, and it's been in times of, and I think probably all of us have a caregiver story. You're in crisis. You are worried about a loved one, and you're trying to find help, and it's frustrating. It shouldn't be that hard to get the help that you need. So we need highly trained professionals manning those lines, and they do have a very good setup that I think could be expanded upon as opposed to starting from scratch with a new system.
I just want to plug senior linkage. We have heard from other states that Minnesota is the leader in that senior linkage line. It is not perfect, and we can all agree with that. And excuse me, Senator Mann, for interrupting your questions, but you said two things in your answer that I want to just kind of call attention to. You initially said we could use AI to help screen the questions. And then in the following statement, you said we need highly qualified people to do with the line. I think when people are in crisis, to rely on chatbots is not a good idea. That's just my personal opinion. Sorry, Dr. Mann, did you have? Okay. Representative Seleznikar.
Thank you for being here and for your presentation. My questions are follow-up to the senator's questions on the care navigation side. I've worked with Senior Linkage Line since it came, and it's a fabulous program. My concern stems from the point of what are we calling in to say you have a need is one piece of the puzzle. But when there's not the services in place in the community to match the need, for example, 70% of the emergency medical service runs for ambulances are non-emergency. So I've spent a lot of time working with ER physicians, and hospitals, and looking at the data, and there are not adequate services for non-emergency transportation for sure in greater Minnesota. So that's a fundamental thing. So they can say, I need a ride to the doctor, but there's nobody to provide the ride. So Senior Linkage gets that information, but it's going into a hole because you take the call, you note the need, but there's not a solution. So that's my concern on that element. On the second part of it is for aging seniors who have complex medical and behavior health changing conditions, maybe not mental health, but behavior health. There are not adequate inpatient beds in hospitals currently. So they could call into the Senior Linkage, and they do call, but the Senior Linkage line can't give them an adequate option because it doesn't exist today. So that's my question on that. My second question, that's just an observation. My question on the transformational study that I'd like to see is when you say that after COVID, there's more of a propensity to stay home. Does the data in that study show the actual percentage changes from 2020, before the pandemic, to where we're at today on that number?
Ms. Peterson?
Yes, it does, but it's also something that the contractors very clearly state in that report. They had information up to June of 2022 and wanting further information, which is why we have worked to then expand the study with them that they're doing right now, because they were saying, we see some return to pre-pandemic levels of usage of LTSS in general. We don't know, is that going to continue or is it going to plateau? Will it eventually return to pre-COVID levels? And it's something that with the original report, they did have an idea. However, they were very clear in saying they wanted further additional data to have more further confidence in that estimate.
Thank you. And Chair, if I could ask just a third follow-up.
One last question, and then we're going to move on to our next item on the agenda.
The last thing is on the transformational part. Have we looked at any care models in areas where we have universities, and when we're looking at models, the thing I hear from seniors in the middle income market is they have their house, it's paid for, but they are concerned all of it's going to go to care. Have we looked at models that have a percentage that on death goes back to their estate, and then a portion goes into a care model and a housing model for life with health initiatives and care initiatives and emotional health and all the things that bring community? Have you studied any of those models in this state and in other states?
Not for the transformational study. I'm not sure if there are other staff within the Minnesota Board on Aging or Aging and Adult Services who are looking further into that. I do want to say there are other people that we did rely on for the concerns about providers. We don't have these services. We know there's a workforce shortage. So that, while that was something considered, and we did have our expert panelists come in to talk to our stakeholders about that, it wasn't the main focus of the study. I just want to make sure that everyone knows that we know those issues exist, and it's just that I have other staff and coworkers who are focusing more on that, and I'm sure they would also be happy to come and tell you more about their work and recommendations.
Thank you, Representative. The last thing I'm going to ask is in the stakeholder group, and I'll go and read who was at the table, I appreciate that. Can you just tell me for today's conversation, did we have public health at the table?
Yep, I know that they were there at the recent, they have been invited to our Own Your Future meetings. We do have one who was at our event. If they were on the stakeholder panel or were considered brought in for expert testimony, honestly, I would have to double check.
Okay, because I think when we're looking at aging, right, public health must always be at the table. So I would just say that to anybody who's listening today. So thank you very much for your presentation today. We may be calling you at a different time to ask further questions if we need them. So thank you so much, and I appreciate the great work that you do for our state. Thank you. Our next presentation today will be the Minnesota Ophthalmologists. And with us, we have Dr. Amy Maltry. When you're ready, if you'll state your name for the record and begin your testimony, please.
Thank you. I am Dr. Amy Maltry, and Chair Cleavorn and the task force members, thank you very much for having me this morning. I am president of the Minnesota Academy of Ophthalmology, which is an organization that represents over 300 eye physicians and surgeons in the state of Minnesota. And I'm looking forward to talking with you about the importance of eye care for our elderly population and areas where we can improve independence and community involvement for those who are visually impaired. So eye diseases are largely diseases of aging. So ophthalmologists are second only to geriatricians in the number of patients over 65 that we care for. And according to the National Eye Institute and the American Academy of Ophthalmology, or AAO, the prevalence of common age-related diseases like cataracts, glaucoma, and macular degeneration is expected to double between 2010 and 2050. And proactive intervention for eye disease can significantly enhance the health of older adults. A study published in JAMA in December of 2021 found that cataract removal is associated with a 30% lower risk of developing dementia. among older adults. So this means considerable improvement in the quality of life for affected individuals and their families with benefits that last beyond 10 years. So this long-term benefit underscores the importance of eye care and timely intervention for vision-threatening conditions. And even simple interventions can make a difference. So for example, the National AAO developed a policy to color code eye drop caps. And this system has been widely adopted and helps patients easily identify medications. So antibiotic eye drops are tan, dilating eye drops are red, steroid eye drops are pink. And patients find it much, much easier to tell me about how they take their yellow cap, purple cap, and gray cap drop than it is for them to tell me how they're using their timolol, brimonidine, and ketorolac. And so this color coding has significantly improved medication safety and ease of use. So sort of along these lines, the mechanics of eye drop administration are also challenging for many elderly patients. The bottles are very small, they are difficult to squeeze, it's hard to aim at the eye, especially for people with limited dexterity. So there are eye drop helpers. These are small devices, they fit around the eye drop bottle, they aid in squeezing the bottle and guiding the drop to the eye. So insurance coverage for these inexpensive devices would help make them accessible and improve medication adherence for some of our most vulnerable patients. And then even more so than eye drop administration, one of the greatest challenges my elderly patients face is transportation. And this echoes a bit of the discussion that we were hearing earlier as well. And when my patients express concerns about their vision, one of their greatest fears is losing their ability to drive, their driver's license, and consequently their independence. Every state sets visual acuity standards for driver's licenses, and most require 20/40 acuity for an unrestricted license. However, there is significant variability among states regarding peripheral vision requirements and restrictions for those who have worse than 20/40 vision. So this task force could recommend that the Department of Public Safety review Minnesota's current driver's license vision requirements to make sure that we are safely allowing maximal independence for moderately visually impaired drivers. And then for those who cannot drive safely, transportation to medical appointments and other activities is a significant challenge. And many elderly patients don't qualify for medical transportation. They can't easily navigate public transportation. And rideshare apps are often impractical for this demographic. And even if they can use them, rideshare drivers are not trained in assisting the elderly. So providing safe transportation options would improve patient adherence with follow-up care, create independence, and improve quality of life. So options to help facilitate trips, say, from rural Minnesota to our regional medical centers of excellence, as well as state support for non-emergency medical transportation services. All of those would be very helpful. And then another challenge that I see all the time in my practice is that of post-surgical care. So after sedation for an outpatient procedures like cataract surgery, ambulatory surgery centers require that a responsible adult accompany the patient and stay with them for several hours post-surgery. And if a responsible adult is not present, their surgery is canceled. So many seniors live alone. They may not have family nearby. They might not have much in the way of friends or community support. They also might not meet the requirements for personal care assistance or for hospital administration after an outpatient surgery. So state support for a program that would provide transportation and aid and companionship after surgery would really alleviate this burden and allow patient access to get these procedures that it can improve their function and maintain their health. So in conclusion, addressing the needs of our aging population requires thoughtful and proactive measures by encouraging coverage for eye drop medication administration aids, by reviewing driver's license requirements, improving transportation options, and expanding post-surgical support. We can significantly enhance the quality of life for elderly patients who face visual impairment. So thank you for your time and consideration, and I appreciate any questions.
Thank you. Please, Dr. Moon.
Thank you, Madam Chair. Thank you, Dr. Maltry, for your presentation. I have just two questions, one sort of for just personal edification, I guess. Given the Institute of Medicine showed that less than 1% of physicians, less than 3% of nurses, and less than 1% of physical therapists have ever taken a course or had any education in geriatrics, do you have any idea on the percentage of ophthalmologists that receive education in geriatrics, particularly given that they are the #2 professional working with older Minnesotans?
Dr. Maltry.
Yeah, Madam Chair. I think that sort of specialty or specific training in geriatrics is very limited. You know, it is really experiential, and you get it in, you know, residency training and medical school, and every ophthalmologist has to do, you know, a general medicine intern year, so you are caring for patients in the hospital and in the ICU. And it's been a few years since I graduated medical school, but you know, I'm hopeful that specific training is increasing because, you know, it's, as we are hearing from this committee, it's getting more and more important as well.
Thank you.
Thank you,
Dr.
Dr.
Moon,
Maltry.
follow-up?
Thank you, Madam Chair. Yes, I have one other question. We've, the task force, which I've been watching, not necessarily actively participating, has had a number of different professions and advocates come before and testify about the woeful workforce shortage issues occurring across our state, including the long-term care providers, geriatricians have also presented. Could you talk a little bit about workforce shortage issues that may be experienced in eye surgery or ophthalmology?
Please proceed.
Chair Cleveland. I think we are very lucky in Minnesota to, I think, have a strong ophthalmology and eye care workforce. But it's a national problem that we've been looking at. And there are a limited number of residency spots each year, and ophthalmology, you know, it's competitive. People want to do it, but there's only funding for so many, you know, training programs, and then also only so much capacity for people to be able to get adequate training in these programs, meaning, you know, if you could get the funding to add more residents, you also have to make sure that they're going to, you know, be able to see enough procedures, do enough procedures, and you aren't going to sort of spread that availability thin. So, you know, as we were thinking about, you know, transportation and getting patients, say, from, you know, rural Minnesota to the places where, you know, really specialty eye care is being delivered, I think things like that are going to get more and more important.
Thank you so much.
All right, thank you. Representative Selesnikar.
Thank you for your presentation. And I think that you're spot on. The transportation is significant. Post-surgery, for surgery, getting to the appointment for seniors. And especially in greater Minnesota, because we have rural hospitals that are not doing the specialties. And so whether it's OB all the way to caring for eyes for seniors. So there is a distance to travel. And we have this thing called snow and ice in where I live, and seniors struggle with that too. And then many of them need to have care in the time that from the moment they got dressed in the morning to leave home, whether it's managing their meds, making sure they didn't take them, didn't drink water, didn't eat, all of that. And so having somebody that has that level of understanding of their environment and then being able to meet their needs when they're transporting them home and being with them, I think you're 100%, and I appreciate you acknowledging that, because there's a lot of miles and a lot of distance. When everyone is in the model of being home, there could be 60 miles before you're at the provider to see somebody. And so it is not a simple thing in greater Minnesota to get people to get the necessary care. And so I appreciate you mentioning that, and that aftercare is critical to not end up having the ambulance called, which will be my next task force, because that's what happens, is they don't have the support, so the only thing they can do is call 911. And then the ambulance is transporting them to the emergency room for that care that we could be preventing. So thank you for your insight.
And then I'll just close this part of the session with, I would really love if you would submit to us what you think the necessary requirements would be for that post-surgical position, because it seems to me that that could be a low-cost or no-cost option for us to help people get the services they need when they need them. And I think it would also be an equity issue for individuals who have family members who can't afford to take off work. So it would be very helpful there as well. Did you have a question? Oh, I'm sorry, Ms. Foley.
You also mentioned the color-coded eye drops. I thought that was an interesting thing. I'd never heard of before. But you also mentioned eye drop helpers and not covered by insurance. What do those cost? And would they be, is it a one-time cost? So if you got a bottle, you could use it over and over again? Or do you have to get a new one every time you get a new bottle of eye drops?
Dr. Maltry.
They are pretty inexpensive, so if you go to say search for one on Amazon, they're probably between $15 and $20, depending on the type, and they can be moved from bottle to bottle. Yep, so I think overall it would be a low cost.
And as I'm listening to you, I'm thinking about my wonderful husband who has had cornea transplants and has very special lenses that go in with a plunger, come out with a plunger, and thinking about how he would age as he needs to fill his contact with fluids and then try to get it in with, maybe a trimmer or something like that. There are things that we can do to try to make these things better. So thank you very much for your testimony. I appreciate you and the ophthalmologists who serve our state. Thank you very much for being with us today.
Thank you.
Next, we're going to talk a little bit about technology, and we have with us today HealtheMed.
She's trying to teach me how to manage the technology.
It's all good. When you're ready, Ms. Miller, if you'll state your name for the record and begin your testimony, please.
Wonderful, thank you. Good morning, Madam Chair and task force members. My name is Alicia Miller, and I currently serve as the Vice President of Growth for HealtheMed. I have served in healthcare delivery for 25 years, with the majority of that being within geriatrics. For context, HealtheMed is a public benefit corporation disrupting what's possible in health by realigning incentives to benefit the customer. We do this by proactively and consistently engaging with our customers through people and technology, which creates new value. I'm here today to discuss, trying to get this down. I may not use the slides, and that, is that okay?
Yeah.
Okay. To discuss opportunities for the aging population in Minnesota, how technology can enable our aging population, and recommendations on it. To do this, let's begin with a few facts. In Minnesota, it is predicted that by 2040, our 65-plus population will be nearly 1.2 million. Each number represents a unique individual with unique needs. In Minnesota, we've been feeling the workforce crisis related to our aging population for over a decade, and we will continue to. Additionally, we are starting to feel the health, disability, and long-term service and support needs of our aging population, and this will continue through at least 2050. We must put policies in place today to support both our present and future needs or the health and sustainability of our communities will overwhelmingly rely on insufficient capacity across long-term care beds, emergency rooms, families, and healthcare organizations. A survey of 2,000 adults 55 plus was conducted by the U.S. News and World Report in 2023 to better understand how respondents use assistive technology to age in place. I'd like to share a few of their findings. 93% of respondents said that the ability to live in one's own home and community safely, independently, and comfortably, regardless of age, income, or ability level, otherwise known as aging in place, is a very important goal for them. That same survey was reconducted in 2024 with 1,500 adults 55 plus and had an increase from 93% to 95% of those that said it's a very important goal for them to age in place. Additionally, 88% of the respondents assert that health-related assistive technology improve their quality of life. 62% shared the cost of living expenses were making it more difficult to age in place. 46% of those who use assistive technology are using a health-related mobile app, and 32% are using grocery delivery apps. This background demonstrates our aging population is growing exponentially. We have a strong desire to age in place, and those aging in place and using technology report an improved quality of life. While technology is adding value, many may not have the finances to afford it. When we consider our problem of how to build sustainable health options for our aging population, while delivering on the triple aim of experience, quality, and total cost of care, we must consider technology as a solution. Opportunities technology can offer are a multitude. To list a few: access, literacy, people supports, and innovation. From an access perspective, it's not simply about computers and internet, rather about social inclusion and equity. We need to connect individuals with technology to offer clinical and support services. This is a direct correlation to reducing transportation barriers that we all know exist. The second component of literacy. This can include both health literacy. If we consider a customized video library with your health needs and goals, and retrievable by you when you want to use it from the comfort of your home, as well as technology literacy, a tech team to teach you how to become tech savvy or at least a tech adopter. The third component of people supports. This can be for the individual related to health reminders and alerts. It can be for the caregiver to have a command center to offer updates and alerts on movement, vitals, and activity. The fourth component of innovation. We cannot continue what we are doing today. A wise person once told me, I'll wink here, the cost of doing nothing is often more costly than the cost of adding something new. Innovation leads to possibilities, and technology can offer this for us. Today, technology options include things such as wearables, telehealth, health apps with AI-enabled chat features, motion sensors, medication reminders, GPS trackers, GrandPad, assistive technology, cameras, Alexa devices, smart home devices, remote patient monitoring devices, et cetera, et cetera. Our population will continue to age every day as each of us continue to contribute to this trend. And we all want to age in place. To do this, we must consider creating a public health utility that is equitable and not based on payer or system. One that places the person in the center to make informed decisions based on their health data. We must ensure this technology creates engagement from the customer, their support system, and their health team. The technology utility must complement current health systems and tools to allow for improved access for the customer and improved capacity for the workforce. The technology must be comprehensive, hence a utility, so it is easy to use, accessible in the home and on the go, create a one-stop shop, be proactive, not reactive, and be complementary, not competitive to current health teams. Remember that health equity matters. Perhaps we consider realigning incentives and engaging state Medicaid recipients in a model to learn from, offering multiple value-based assistive technology initiatives to best understand how to proceed sooner versus later. Technology will create improved health experiences and outcomes by changing behaviors real time while simultaneously saving time and money. If I can further explain how HealtheMed might contribute to our present and future aging health needs, I would be happy to. And I'll close on creating and implementing technology at scale is certainly no small feat, but a worthy accomplishment that will require a coalition and/or collaboration of not just one person or entity, but a multitude. Thank you for the opportunity to share today, and I'm happy to take any questions.
Members of the task force, do you have any questions? Ms. Schneider.
Thank you, Ms. Miller, for your presentation. I very much like the concept of utilizing technology with the elder population. I have tried it in the past, and I haven't been very successful. I've reviewed a number of companies, everything from sensors on doorways to underneath mattress pads. I have looked at the various med reminders that were speaking to the person that it was time to take their meds. And when I asked about the effectiveness of that, they said, yes, I just shut it off and go back to sleep. And so my question is, how do we make this conversation, these dialogues about assistive technology more realistic to the average consumer? Because I believe that it makes for great talking points. And I think even we could resolve the money question, which would still be a question, by the way, because these things don't just fall out of the sky. But it also, it gets down to you build enthusiasm and then it doesn't work for them.
Ms. Miller. No, that's fine. Go ahead.
Thank you for those comments. You might be above average, we'll give you that. But Ms. Schneider, I would share that I think one of the biggest limiting factors with technology is not supporting the technology with people. So in many instances, technology is sold on Amazon, for example, and it does sound and look enticing. And then when we order it, we receive it, and we have to do it all on our own, that becomes very challenging. So I believe that we need people to come into the home to educate those that are using the technology on how to use it, and not just a one and done, but an ongoing support mechanism, both telephonically as well as the ability to come into the home to do that. Thank you.
Other members? Ms. Selesnik, sorry, Representative Zeleznikar.
Thank you, Chair, and thank you for the presentation. And I just want to piggyback on that piece because Ms. Schneider's correct in the fact that all we have to do is have the power go out and seniors panic because they have to reboot it. There's multiple remotes and they struggle. So I think the technology is great, but the other thing to remember is that as people decline in that lane, their long-term memory's there, but the short-term isn't. So I'm wondering what strategy there is to educate seniors before they're 85, because it's very difficult to get the recall in there, to that comfort. It was just like introducing microwaves. I mean, we'd practically have buildings burnt down because they would set it to 2 hours. They can't see the buttons. You know, it sounds simple, and how couldn't anybody understand how to use it? But they didn't grow up with this, and they don't understand it, and they can't see in the same capacities. And so I'm concerned with, how we're going to do that, because I've tried many of them. Some of them have worked great, and others have not. But I do think the apps that the families can have control to see, to be the reminder, the voice to call, it helps support, or a friend, somebody in the community, helps the seniors stay effective at home. But I'm wondering, as we look at these things, the idea sounds great. The application, when we're dealing with an 85 or 100-year-old, and there's many of them living at home in greater Minnesota. When I look at this map, it validates what I've lived. They are at home, but we could bring that to their house, and if I showed up or you showed up, they would look at me like I had 10 eyes on my head. And so it's intimidating. It's difficult to absorb that at 100. And I wonder what we're doing to introduce some of this sooner, so the long-term memory would maybe stick on some of it, on the things that we decide are easy, or we label as easy use. Thank you.
I would just like to add that when my mother-in-law was 85, she was way more tech savvy than I was in my 50s. So, we all deal with technology in different ways. I have seen the prototypes of your systems in place, so I just want to be transparent about that. And I do find them fascinating, which is why we've invited you here today. If you would like to go ahead and answer the question about, what do we do with power outages, rebooting, and how you believe that technology can help those with dementia and early onset. Thank you.
Thank you. And Representative, I agree with all of your comments, right? There is no perfect solution, and there will always be opportunities for technology or different services that don't meet every individual needs, right? So I would in no way sit here and say that technology is the only solution, or even one that meets the majority of the needs, right? I think it can meet many though, right? And if we look at our aging population, and there are, 30 or 50% that it can impact and help support, then that is a meaningful difference in how we look at health impact and population health. I do agree that early adoption is key. Don't give me a different phone that functions any differently than what I got 20 years ago, right? Just keep upgrading and that's it, right? So I am also in that boat of what I use today, I would like it to be consistent. So I think it is really important to have the early adoption versus introducing something to someone who is 85 or 100 potentially. Not to say that isn't possible, but early adoption. I also think that in the healthcare continuum, technology is part of that continuum. So it will change over time, and we have to be agile to change and meet the person's needs along that journey. And the other thing I would just add, and final comment, would be that there isn't one technology, right? While I work for and represent HealtheMed, it is not the only technology that is a solution for people. We have to have the breadth of technology options as well as services, and then be able to identify, if it's option A or option D that's best for that person and it creates value, then we use that at that point in time, right? And I think I said these words earlier, but we cannot in health be competitors. We have to be collaborators.
And I think that's a really important thing. It's not going to be one thing. It's going to take all of us working together to solve this monumental task, as you, Representative, and I spoke about earlier today. Thank you. Thank you very much. Ms. Foley, did you want to? Okay. Any online question? All right. Thank you so much for being here. I appreciate your testimony.
Sorry I couldn't go through the slideshow.
That's all right. We can read. It's all right. Thank you so much. Next on our agenda, we have Dr. Bruce Corrie. Welcome, Dr. Corrie. It's always an honor for me to be in the same room as you, so welcome to the task force. If you'll state your name and just say a little bit about who you are and then begin your testimony, I would appreciate it.
Thank you, Chair Claiborne and members of this committee. My name is Dr. Bruce Corrie. I'm a professor of economics at Concordia University and also in the community operate under the Alana Brain Trust, Alana standing for African, Latino, Asian, and Native American. It's demographic groups that I focus my research and action around. And so it's a pleasure to be here this morning. It's also a very busy time for me, and ordinarily, as you know, I would have a presentation up there, but I have a booth at the State Fair where I'm featuring 40 different businesses, cultural businesses, to give Minnesota an experience so stop by the Education Building. But I also share that for who you are, or this committee is talking about me. I'm the demographic. And I just told you about what this demographic is doing in the State Fair to create a space where everyone enjoys culture. And I want to offer a similar frame to this committee because you are dealing with an issue of aging, that there is an opportunity for a great handshake. I would call it the Alana handshake, African, Latino, Asian, Native American. What we give to Minnesota and what Minnesota gives to you in a way that everyone benefits. So let me provide a little bit more context to that statement. I once estimated that the Alana workers in Minnesota represent in terms of lifetime earnings $1.4 trillion. So you can see that energy that they bring in both in the economic sense and the workforce and the taxes that they're paying. So they're not an invisible entity, they're a very active entity. And the kids, the youth in the workplace, the future workers of Minnesota, they also represent 1.5 trillion if they all get a bachelor's degree. So the opportunity when I look at the statistics that the state demographer shared in this committee, and seeing the demographic change between who is aging and who is offering services like in healthcare facilities, there's an opportunity for that handshake. So let me again talk about some elements of that. Aging in place. If I am an immigrant from India and I'm your medical doctor, or I'm your radiologist, or I'm your nursing home assistant. And if I don't know your culture, I don't know how you celebrate Thanksgiving. I don't know what you do about ice hockey. I don't know how you like your Christmas or whatever religious celebration you have. Because I've never been into your dough. I've never been in your community. I've never been in your... How can I help you age in place? And flip it. If you don't know anything about me, that I really like that spicy pickle in my food, and you offer me a bland pizza, I will accept it with grace, but I'm not totally in there, right? So how can we create a system where it's a handshake where everyone is better off? And that's what I think you have a very unique opportunity. I'm glad you're chairing this committee, Chair Claiborne, because you are one with vision and with courage and with the opportunity and with the ability to do things. So thank you for that. Just an aside, hearing what was happening, you talked about technology, and here's a funny story for you. So I'm here, an Asian American, and I'm hearing all through the session people talking about the importance of Asians. But you're talking about aging, right? So how can I be listening here thinking you're talking about Asians, because I'm hearing Asians, and those little monitors out there, I can't even read, except if you are at home and you can read it. So how could technology then help us to be more effective, right? So this is a little example of I try to speak better and louder in the phone, in the microphone, and people should do it to make sure that everybody enjoyed geriatrics that you mentioned. I went for my medical care recently, and the physical I had was not as good as I had years ago when I was not at this stage. So I'm wondering what's up, right? So you're right. People are not trained to also be the cultural nuances of aging. And so there's a lot to groom. So while thinking about it, I offered this framework of looking at the aging in general, but also in terms of the Alana communities. And you know, that little graph, a picture out there, beautiful picture, that was done by ChatGPT. Isn't it pretty good? So I'm not a painter, but I love painting with ChatGPT, and they bring out such beautiful designs for me. But I want to talk about these elements. First of all, how do we talk about each other? If you talk to me as that I'm a senior citizen, I'm the elderly, you're going to turn me off, and it's going to turn me off my 80-year-old friend who in his mind today, he still thinks he's a 25-year-old hippie, and Chief Cleveland, I met him, just came in from America. But that's what people, in my mind, I'm always 45, and I'm not going to be changing from that. But how do we talk about us? And I suggest elders, but it may not be for everyone. But elder has a connotation that brings with it dignity and respect compared to the other terms that we use. And so we talk about this community of elders. How do we create a space for this community of elders? And this is where these elements come in place. So you've heard a lot about aging in place. I won't go into that, but I want to add aging in cultural place. Because even though the numbers are small right now, we need all these places to reflect the cultures of people. So people, when they are in a nursing home, but they don't know how to be connected, or nobody connects them, right? So because the cultural way of looking at things would be, I need to be invited in. I'm not going to step into something, right? Or the kinds of flavors that are offered, as I just mentioned. No pickle in that nursing home, I'm out of there, right? So how do we bring all, and the physical spaces, we are spending millions and billions on housing and affordable housing, but we're not building things that meet the need of multi-generational households. So aging and cultural place. Then we have aging in grace, right? How do I feel respected, that I belong, that I'm valued, and how is that reflected in everything that we do, in every situation that we have? And so I have a written thing that I will send to you, but there are some action steps about doing surveys on these institutions of nursing homes and all these institutions and healthcare, and finding out, do people feel they belong there? Are they treated with the respect? How do you navigate? In terms of technology, there's an Alana gentleman I know, a young guy. He's developing these avatars. People who, so I got it, I'm going to make one like me, so you'll have me forever, right? So you put all the stuff into this avatar, and this avatar will reply back to you in any language. For example, his latest thing is on prescription medicine. He has one on legal systems, where anybody can ask them a question. What does the legal code say? And it'll reply back in the language that you have. So they have all these languages in the world into this thing. It's kind of, a world forward is going to be very easy to do it and very cost effective too. In our Alana communities, there's a big tradition of treating Alana as elders, as people of respect. But what we also happening lately is that we have grown up, this first generation, in a way that we treated our parents. But our kids have grown up here, and there's a something not sinking. And as a result, there's a lot of anguish and heartbreak and problems that need to be addressed and educated about it. Aging and planning. And so as we think about the future, you had some good, tough questions to the presentation on long-term care, because I also wonder, why would I put $100,000 into long-term care? I don't know that company is going to exist when I need it, and whether I'm better off taking my $100,000 and investing myself so I know I'm controlling the money, right? So how do we start helping people think? One of the things that helped me a lot was Peter Drucker, and he talked about 2 careers. Your primary career is where I am as an economist. But as I'm working as an economist and professor, I'm thinking about my second career when I cross the finish line, right? And on going into the Medicare card. What am I doing there? And how can we help people think about these alternative pathways? It's good to see in that data that was presented that a lot of people in this demographic age, 65 and above, are actually working, right? So how do we offer these workshops? There are cases of even people committing suicide soon after retirement because suddenly their reason for existence is gone. And so how do we prepare people for that? And also, I applied for Medicare, and I know if I had problems in the way the sign-up happened, what about people with language difficulties? What about people who couldn't ask the question? And I got some high-powered people to give me an introduction to in the system to do it, and still it didn't work as well as I thought it would be. So if I was having that problem, what about that person who doesn't know what even to ask? And so how do we get there? Then aging and relationships. Again, going back to the mental health issues that people face as they themselves change from that transition from being the breadwinner of the family to now being dependent and being in a different relationships. And this, I believe, is happening a lot even in our communities. And finally, what I talked about in terms of this handshake and legacy, not only the legacy of what I am leaving behind, but how can my talents be used in a way that can help the next generation? And so, for example, having grandparents in childcare centers, right, where they are naturally can have a big role to play, or in short-term jobs in key positions going through transitions where their expertise can help address an issue. So how do we develop those talent pipelines and help in the transition, but in the workforce? And this is a whole big discussion that's happening indeed. I looked at the data. There's so many sectors in the economy where population 55 years and older is over 25% of that particular sector. So who's filling that? Who's filling those jobs? And how do we get people ready for those jobs that we need? So I invite you to host a special session on the Alana handshake. That is, what are some ways in which the Alana communities can help Minnesota and are helping Minnesota currently, whether it's the nursing homes and the whole discussions about proper pay and conditions and all those things, but also in the workforce and what they need to have transition, because they are the people who are going to bear and support this economic needs of the aging population. So how do we get them in that place that is right? And on the other side, how could the system, which is not being used to see Alana people from the founding of this country, so that the institutions are not ready because they haven't seen it and not, how could those institutions start adapting to see them and integrate them? And so in just the 48 hours that I started, receiving the invitation and trying to frame something to you, I talked to a few people, and their names will be in the past of this. Look, I've heard about in Native American communities a net zero model and other kinds of issues happening in the county. And so I could work with you to help bring people in and for us to develop a better, stronger system in Minnesota where people at every age can say, I belong here. Thank you.
Oh, Dr. Corrie, I love being with you. Okay. Task force members, do you have any questions? Representative Selesnikar.
Thank you for being here today, and I enjoy everything you always say. And I'm curious on your thoughts on intergenerational housing for families as we move forward in the state of Minnesota. Greater Minnesota at one period had intergenerational homes to care for people in models, and that went away in the last decades. And I know in many other countries that's a strong model. And I wonder your thoughts on that. If you see that, any of that coming back in the metro areas and the suburbs and also for greater Minnesota, and if so, what you see that looking like. Thank you.
Good question, Chair and Representative. I also respect the questions you bring at the different forums and as we talk about issues. I'm involved with a community survey in St. Cloud with internal housing assistant. Omar Podi is the executive director, and we are asking people questions. And one of the things that strikes out as I look at preliminary data is these large households. 14 in a household, like you think, there are some people who said 14, right? So who are the 14 people? Multi-generational households that are there. So in the Hmong community, I believe that also is the case. So in the new immigrant community, you're finding that happening. But also with the happening, I think there are also the tensions and the change between now living in America and the old system, and how these communities too need resources to think through and but out of it also coming some very interesting models, what I've heard about how they bring the elders to other areas where they feel valued. So during the day, they are at the daycare center and working with kids or something like that, or reading to them. So there could be a way to nurture that environment, because it's a very wholesome environment. And personally, we had the luxury in our family to have grandparents, or at least a grandparent around to be with our kids, and that had a great impact on their own lives. So I value that. And maybe we have to think about that, how do we nurture those models of living too.
Any further questions? Ms. Schneider.
Thank you, Madam Chair, and thank you, Doctor. As I was listening to you talk about how do we respect and value, one of my concerns has been with workforce shortages in caring for elders. And I know that folks who operate housing for seniors, assisted living, et cetera, they are working hard all of the time to make sure that they are sufficiently staffed. But it doesn't always happen that way. And one of my concerns has been the fact that sometimes when you are in a pinch and you're short-staffed, it's a little easier to leave some of the graces out of things, the respect. Not that I'm not talking malpractice or mistreatment. I'm simply saying that sometimes when we're in an area where there's a scarcity, some of the nuances can fly out the window. So I really appreciate you bringing that. And then the second thing that I would like to have your comment or your thoughts on this whole concept of ageism, because it is rampant. And as I've gotten older, I have resented it more and more. So I'd like to have you comment on that, if you would, please.
Dr. Corrie.
Thank you for those two important points. And I was just at a conference with the census director, so I know that something high up the chain has my same problem. He said, when you give me 1 and 2, I usually forget what the 1 and the 2. So the first point was, may I ask you again, what was your first point?
the nuances of kindness and
No,
short.
that I got, but the first one?
And then the next one was about, I have to write it down, the scarce ageism rampant in our society.
Yeah. So the ageism, we've just been through a hectic political storm where we've seen it in clear light about age. Age has become the issue about defining who we are and pointing to the fact that age, people who are older are not competent in whatever they do. And so that age stigmatization is there. And you also have counter images too of people who are fairly well in age who do well. So trying to educate people on the different levels of energy that happens at different stages. So when I'm a young person, I can lift 200 pounds. But when I'm at my age, maybe I don't have to lift 200 pounds. I can just do it with a breath, all right? I mean, the energies that can happen and I can do might be as powerful as that. And for people to understand that to get things done, it's not necessarily physical and all these other cognitive things that you think is important. Allow the freedom of others, of people to develop and add their creativity to what is going on.
Okay. Any further questions? Dr. Corrie, I want to thank you for the invitation for the Alana handshake. I think that's an important thing, and I'm going to ask Mr. George to reach out to you. I would love to have that conversation and to bring the Alana community to the table, because what you said about who is receiving the care today and who will be providing the services, it's so important. We can't, as we build community, it has to include everyone, and it's all the way through the life cycle. And I think that's a really important piece to bring to this conversation. Having been fortunate enough to live outside of the country twice, I understand that we have an intellectual vocabulary and we have a functional vocabulary.
Mm-hmm.
And they don't always align. And sometimes we are judged by our functional vocabulary, and we are seen as less. And that is never a good thing, right? So to have things that are language appropriate, whether it's an avatar or the person in front of us, is really critical. And I'm glad that you raised that language issue as well in this conversation. So thank you for being here, and I appreciate your coming at such a late notice, and I'm sorry I didn't call you sooner.
No, but Chair, just I remembered what a commissioner member asked about nuances and things letting go. I think that's an important point. One is, I think we need to pay our workers at those facilities more, so because they very often are juggling 2 or 3 jobs, right? And is there a likelihood that grace might slip? Yes, right? So you've got to figure out ways in which that whole healthcare workforce is a top priority, and it is, but how do we start getting those elements in place to do so? And then once you are there, I think a culture of that is encouraged in institutions that know those little things matter, right? Yeah, if you have decided to be in this job, you have to take care, you have to maintain the dignity and respect of people. And there are a lot of people who do that. And there are a lot of models within the healthcare system of people who are doing it well. So we lift up those people and help educate the other ones that here's how we can make it work well for everyone.
Thank you. Members, we seem to always get into our conversations about, thank you, Dr. Corrie. Thank you so very much. We seem to get into our conversations and our testimony, and we don't get to our questions that are on, our public questions that are there. So I need us, today we do have a hard stop at noon because Mr. George and Representative Selesnikar have another task force they must participate in. Mr. George, is there anything that we need to be aware of as far as scheduling is concerned for our next meetings?
Thank you, Madam Chair. We will be holding another meeting in August. That date is not confirmed yet, but likely early to mid-August for a discussion on these questions and recommendations.
And we'd like to have the full 2 hours to discuss and to allow members of the public to engage in the conversation and with the questions. So please keep your eye on the website for the date and time for that meeting. Senator Mann, Vice Chair Mann, do you have any closing comments about your first meeting?
It was wonderful. Lots of really, really good information and good input. So I'm happy I'm here.
Okay, we're really excited to have you with us. Mr. George, anything else that I'm forgetting? All right, I think we are going to go ahead and adjourn at this time, and then please look forward for that August meeting. Thank you very much. We are adjourned.